It's 8 o'clock.
Thank you. Shall I, Sunil? Sunil?
Now, yes, we can. Actually, it takes 20 seconds. We are live, sir.
Okay. So good evening, friends, and let me wish you all a very happy new year quite in advance. Welcome to this special episode because this is the 25th episode of our All India Postgraduate Teaching Program, which was a new initiative launched by the team ARCAS in this session. This is a postgraduate program with a difference because we cover the uncovered aspects of other teaching programs like case presentations, journal clubs, OSCEs, and didactics on topics which are not necessarily comprehensively available at a go in a textbook. So this is a special episode, as I said, 25th episode of the series and the 7th episode on case presentation. Today we have two short cases which would be presented. The first case would be presented by the second case would be presented by Dr. Meghna Kandi, who is a second-year resident at AIIMS Nagpur. And the first case would be presented by Dr. Arsha K. Joshi. She's a DNB final year resident at Comtrust Eye Hospital, Kozhikode. I'm especially thankful to the mentors, Dr. Pooja Hingorani, Dr. Bank, who is a professor and head of AIIMS Nagpur, Dr. Purvasha Narang, who is associate professor and a cornea consultant at AIIMS Nagpur, and Dr. Arjun V, who is a consultant cornea and ocular surface specialist at Comtrust Eye Hospital, Calicut, for mentoring their VGs well. Of course, my special thanks goes to the external examiners for today, Dr. Nidhi Pandey Madam, who is a professor and head at RIO Raipur, Dr. Radhika Natarajan, who is a deputy director, Department of Cornea and Refractive Surgery and head of the Department of Teaching and Training at Shankara Nethralaya, Chennai, and Professor Bella Konda, Dr. Giridhar Sir, who is a professor and head at Department of Ophthalmology, Kakatiya Medical College, Warangal. I'm really thankful for sparing such with their valuable time at this hour on a year end with my students. Last episode, the viewing was 2037. In fact, this viewership for the every episode varies from 1500 to 4000, and the last episode was about 2036 within 7 days. Now, can I request Dr. Araksha Joshi to share her screen? Also, let me, before I ask the Arsha to share her screen, let me also welcome my member ARC Center, Dr. Deepak Mishra, who is also a faculty at Banaras Hindu University. He being an anterior segment surgeon, I would request him to carry forward the further proceedings. And Dr. Arsha, over to you. And Dr. Deepak, your job starts now.
Thank you, sir. First of all, Dr. will present her first case. After that, we will start discussion with the experts, and experts can ask question in between them. If you want that anything is important in between, then you can stop her. Otherwise,
Sir has logged off.
I think. So the thing is, once more, for the examiners as well as the mentors, you can stop the student while they are presenting. The cumulative time for their case presentation is 10 minutes. If you stop them during presentation, well, that might be added upon. And 20 minutes is total quizzing time for each case. So I think Deepak had logged out. Arsha, you can start now.
Okay.
Welcome, Dr. Deepak, well, again.
Thank
Yes,
you, sir.
Arsha, you are ready. Go ahead.
Thank you, sir. Good evening, everybody. I am Dr. Arsha K. Joshi. I'm a DNB resident in Comtrust Eye Hospital. I'll be presenting a case under the guidance of Dr. Arjun, sir. Presenting a case of 65 years old female who is from Calicut. She's a housewife. The chief complaints are pain and foreign body sensation in the left eye for the past 10 days, and there is diminution of vision in the left eye for the past 7 days. History of presenting illness. Patient was apparently normal 10 days back when she started as a sudden onset of pain in the left eye on waking up in the morning. It was dull aching pain. It was associated with foreign body sensation, watering, redness, and difficulty in looking at light. She gives a history of rubbing of eyes and washing of eyes with tap water. She used indigenous eye drop, that is tincture of tender coconut, but there was no relief of symptoms. Hence, next day, she consulted a nearby ophthalmologist and was started on topical eye drops. The following day, she experienced defective vision and noticed an yellow patch in the left eye. Hence, subsequently, she was referred to us for further management. There was no history of any foreign body fall or any ocular trauma, no history of bathing in ponds, no history of use of contact lenses. Past history, she is hypertensive on medication for 4 years. There is no history of any similar illness in the past, no history of prolonged use of any topical or systemic medication in the past, no history of any previous ocular surgery, no history of diabetes, bronchial asthma, or tuberculosis. Drug history, there is no drug allergy. She is now using topical eye drop for the past 3 days. Personal history, no history of any addictions. She takes mixed diet, normal sleep and appetite, bowel and bladder habits normal. Family history, there is no any similar complaints in the family. There is diabetes for her 2 sisters. General examination, she is conscious oriented, moderately built and nourished. There is no pallor, ictus, cyanosis, clubbing, or regional lymphadenopathy. Vitals, pulse rate is 80 beats per minute. Blood pressure is 130 by 80 mm of mercury. Respiratory rate is 20 beats per minute, and she is afebrile. Systemic examination, cranial nerve system, cardiovascular system, respiratory system, and gastrointestinal system are within normal limits. Coming to the ocular examination, head posture is normal, no facial asymmetry, eyes appears orthophoric, there is no proptosis or ptosis, extraocular movements is full. In the right eye, uncorrected visual acuity was 6/12, and with pinhole it was improving to 6/9, and near vision is N12. In the left eye, visual acuity was hand movements, and there was no improvement with pinhole. Coming to slit lamp examination, since the symptomatic eye is left eye, I would like to present left eye first. Eyelid, there is mild lid edema, there is no lag of thalmosis, skin over the lid is normal, eyelashes is normal, no trichiatic lashes, no blepharitis or meibomitis. Adnexa is normal. There is no pus on applying pressure over the regurgitation of pus on applying pressure over the lacrimal sac area. Conjunctiva, there is diffuse conjunctival condition, circumcorneal congestion, and conjunctival condition was there. Examination of the cornea. Cornea is normal in size and shape with loss of luster and transparency. A central corneal epithelial defect of size 5x5 mm. An underlying was seen. Underlying cornea shows a 7x7 mm central circular corneal infiltrate, which is dry looking with feathery margins extending from anterior to deep stroma. With mild surrounding corneal edema, seeing difficulty, mild corneal thinning was noted paracentrally. A dense yellow-colored lesion seen adhering to the endothelium, suggestive of endothelial pain. Peripheral cornea shows superficial corneal vascularization at the inferior quadrant. Rest of the cornea was clear. Corneal sensation is normal. Coming anterior chamber examination, there was thick immobile hypopyon of 4 mm. Iris, rest of the anterior segment details was hazy. Iris details hazy. Visualized iris was brown in color, normal pattern, no NVI, no synechiae, no areas of iris atrophy. Pupil was central 5 mm, pharmacologically dilated. And lens details is hazy. Early lens opacity was seen. Anterior vitreous space was hazy. Fundus examination, distant direct ophthalmo dull reflex. An indirect slit lamp examination with 90D and indirect ophthalmoscopy, media was hazy due to corneal lesion. Intraocular pressure digitally was normal. Coming to the examination of right eye, eyelid, lashes, and adnexa is normal. There was no pus on applying pressure to the lacrimal sac area. Conjunctiva was normal. Cornea was normal in size, shape, and is clear. Corneal sensation is normal. Anterior chamber span hair is grade 3, no cells or flare. Iris is brown in color with normal pattern, no NVI, no synechiae, no iris atrophy changes. Pupil is central 3 mm, round and regular. Direct and consensual reflex is brisk. Lens shows nucleus sclerosis grade 1 and anterior vitreous trace is clear. Distant fundus examination, distant direct ophthalmoscopy, there was red glows present. Slit lamp examination with 90D, media is clear, normal in size. Vertically oval disc with well-defined border with cup-disc ratio of 0.3. NRR is pink and even. Vessels is normal arising from the disc with an AV ratio of 2:3. Foveal reflex is present. Indirect ophthalmoscopy, fundus findings confirmed with periphery is normal. Intraocular pressure with Goldman appellation tonometry was 16 mm of mercury. Summary. A 65 years old female who is hypertensive presented with complaints of pain and redness and foreign body sensation for the past 10 days duration and defective vision in the left eye for 7 days. On examination, her uncorrected visual acuity right eye was 6/12 was improving to 6/9. Left eye, it was only hand movements and was no improvement with pinhole. On slit lamp examination, shows a central deep stromal, dry-looking corneal infiltrate with an overlying corneal infiltrate of 70 to 7 mm with an epithelial defect overlying, which is of 5 into 5 mm with hypopyon. Both eyes shows early lens opacity. So my professional diagnosis is left eye central corneal ulcer, probable etiology fungal, immature senile cataract both eye, and hypertension. Thank you, sir.
Yes, Asha, am I audible?
Yes, ma'am.
Yes. So
Yes,
in
ma'am.
your history,
Yes.
you said about pain, redness, diminution of vision, but was there also photophobia? Because that is a
Yes.
very important.
Yes, sir. She complains of difficulty in looking to the light.
Mhm.
There was photo.
But in your summary also, you had not mentioned about photophobia. It's very important to mention photophobia. And you have drawn very good diagram.
Mhm.
Only thing I noticed was that you mentioned there was thinning, but did you draw that thinning part? The thin part, did you
Can you show
mention
the
in your diagram?
picture?
And
Yeah,
actually, in the frontal view, you can actually denote that which part of the slit you have made the diagram.
Okay.
It was a very nice presentation, Arsha. Can you hear me? Radhika here.
Yes, ma'am.
Yeah. So first we'll start with a suggestion and then a question. The suggestion is that while you had done a very exhaustive end-to-end presentation, you should also learn to, curtail on the non-essential facts. You state some facts for the sake of stating, like, for completion's sake. So there is no need to go into such detail in them, because then the examiner will not have enough time to ask your questions. S1, S2, heard, not heard. Cardiovascular examination is normal is enough, unless there is a cardiac problem which is directly related to the eye condition or its treatment. So learn to limit on that part and elaborate more. Like the previous examiner said, it is imperative to mark the area of thinning and also represent it in the, slit diagram. So now that you have the clinical picture over there, even before we jump into the conclusion of an infective keratitis, which is a corneal ulcer due to fungus, what in this patient suggests that there is an active problem? Do you think that this is an active problem or a healing problem in the cornea?
Ma'am, I think it is an active problem.
So what are the features that point towards that?
So, ma'am, from the history, patient is having symptomatic. She's some complaining of pain and redness and watering and difficulty in looking to the light. And she also noticed seeing an defective vision within 3 days, and there was white patch over the eye. And coming to the examination part, corneal picture, it is showing that the coming to the infiltrate, there is epithelial defect.
Before that, you started on the history. The patient is symptom. So you have a congested eye.
Yes,
okay.
ma'am.
So even before that, you gave a very detailed account of evaluation of the lids and lashes. So you should also start with matting of the eyelashes, circumciliary congestion. So these are all features that you have an active problem at hand. When you speak about infective keratitis, circumciliary congestion would be more apt to describe than conjunctival congestion, which may be because of eye drops and such. Then, what are the other features of activity over here?
Ma'am, the ulcer is epithelial defect is present, and infiltrate is large, that is 7 to 7 mm.
Why is this not a corneal scar? I agree with you, this is an infiltrate. But why do you think this is an infiltrate and not a scar? A whitish central corneal opacity could be a scar also.
Yes, ma'am.
What makes you think it's an infiltrate? It is, but why?
Ma'am, there is signs of activity, like it was overlying epithelial defect is there, hypopyon is there, and the margins
Feathery
are
margins are there. Excellent. I
margins
think you
are
covered all
feathered,
those. I think
and
you
it is dry looking.
and thinning. So you covered
And
all the
thinning.
points which represent an infiltrate. Yeah, go ahead.
Then, ma'am, it is dry looking ulcer with feathery margins, and hypopyon is also there. and it is involving more than 2/3 of the cornea. It is extending anterior to the deep stroma, and ulcer of the size is large, that is 7 into 7 mm, and hypopine is also present, which is 4 mm.
So these are all features of activity, right?
Activity,
My last question before the next examiner wants to ask this: are there any features of healing that you see? The patient came to you first, right? The patient has not been on any eye drops or treatment elsewhere. That's what I understood, right?
Yes, ma'am.
Yeah. So are there any features of healing that the body is taking care of this infection? Not wholly. You did mention them in the course of your presentation and in your diagram also.
Yes,
Is there
ma'am.
anything to show you that, a little bit of healing has kicked in?
Ma'am, since there is no satellite lesions are not seen.
It could be
So
an
this-
evolving ulcer. They may
Yeah.
come later.
Yes, ma'am. And
Inferiorly, you
Not
said,
there.
mention something?
Yeah, you've drawn it in your diagram. Look at your diagram.
endothelial plaque.
Endothelial plaque is not a feature of healing, my dear. It's
No,
activity.
That
It
inflammation.
means the fungus is growing inside the anterior chamber.
And corneal vascularization.
Exactly. You did mention that certain parts of the lesion are looking whitish in the periphery, which may mean early scarring. Okay. And also you have drawn vessels. So these are features to show you that some natural healing response is happening. Yeah, good. But most of the answers were correct.
So what grade this corneal ulcer would fit in? How do you grade the corneal ulcers?
Ma'am, this will be the severe corneal ulcer according to the Jones criteria. Since it is more than 5 mm and it's involving more than 2/3 of the cornea, and hypopine is also present, it will be severe corneal ulcer, which is grade 3.
Right.
So how would you proceed with the case, ulcer?
Ma'am, main aim of the management is to identify the predisposing factors and confirm the organism and to treat the case. In this case, we have to look for the patient is not diabetic, but we have to look for the glycemic status, and also we have to make sure that the nasolacrimal duct is patent, so syringing has to be done. And after that, we have to do the scraping has to be done, and the staining smear preparation has to be given for 10% KOH wet mount and gram stain, and also the culture has to be done, which is for blood agar, chocolate agar, and also Sebrous agar or potato dextrose agar to rule out any fungal in presence of fungal organisms. In this, the patient's KOH 10% KOH wet mount showed fungal filaments.
So I'm going to stop you right there. What if it didn't? You're answering very well. That is why I'm asking you a little more difficult question. What if it didn't? What if your smear came negative? What would you do then?
If the gram staining is also negative, then we have to, since the clinical picture is more suggestive of fungal, we have to start on antifungal medication. And we have to monitor the patient. The response has to be assessed within 24 hours. If it is better, we have to continue. And if it is not responding, we have to re-scraping can be done.
Excellent. And what else should you do? If it is not responding, or even if it is responding, only your smear came negative. So what will you keep checking for?
We have to wait for the culture report.
Exactly. So I think you gave both the right answers. You will wait for the culture report to come. You will start empiric treatment because there's a high degree of clinical suspicion. But over a period of 48 to 72 hours, if there is no response, then no organism, no response, double negative. So you need to re-scrape the patient.
Asha, can you tell me how do you scrape? What are the steps you follow when you do the scraping?
Madam, we have to, after explaining to the patient the procedure, 0.5% of proparacaine eye drop has to be placed, and under slit lamp examination using Kimura spatula or backpacker blade number 15, the corneal scraping has to be done from the site of the infiltrate. First, we have to remove the mucus and plugs and other secretions. Then we have to do the scraping in one direction. We have to avoid the area of thinning to prevent any perforation. And then we have to prepare the slides, the gram staining.
Where will you scrape from? You said you have to avoid the area
From
of
the
thinning.
base and the margin of the ulcer, we have to scrape.
Is there anything else you will avoid except the area of thinning? Is there anything else you want to avoid? You rightly said base and the margins. Any other area you want to avoid? You also want to avoid the area of scarring, so you will not get any
Yes, ma'am.
organism, right? Yeah.
Yeah.
Go ahead.
Then we have to send for gram staining has to be done, and also KOH 10% KOH FET mount has to be done, and blood agar.
What will you, 1 minute, what will you do
Sir.
first? Will you inoculate into the media or will you examine under KOH mount and gram stain?
So first we will examine in KOH mount.
No, no. You have to inoculate in the media because you are dealing with very tiny amount of tissue. So first culture, I mean, this is
Yes.
my viewpoint. First culture, inoculate it, then scrape it again and examine for KOH and or gram stain. First thing you have to do is inoculate. And how will you place the blade on the corneal surface? You have taken a number 15 bar Parker. What is the direction of the blade? So that you don't accidentally perforate, right?
Not perpendicular.
You will scrape it like this
Actually-
or like this.
Angulated slightly.
So you keep it horizontally
Okay, sir.
and then scrape the edge of the ulcer where you get maximum after removing the mucus secretions. And how will you get, where would you keep all this media? You'll take the patient to the microbiology lab or you'll get some of the plates and keep it in the fridge. What's there in your hospital?
Sir, we actually place it give to the lab, but transport medium. Sir,
For us, we have, as you said, we keep in the hospital fridge and we thaw it and then take it for use. We don't have a lab in house, so the media is
So
kept.
what is the first medium you inoculate?
Sir, blood
Inoculate the
agar.
broth and then
Yes.
send it to the microbiology.
Sir,
Do you inoculate into a broth and then incubate it and then the microbiology people do it, or do you directly inoculate what you have scraped onto the plate or blood agar plate?
Majority of cases directly.
Okay, indirectly, how do you inoculate the plate? After 3
inoculation.
years, the microbiologist says, I think it's contamination. So these are important points, no? You have done so much hard work, you've got the plates, you've got everything.
The
If you
inoculation
don't
is
inoculate in a particular pattern and tell the microbiologist, I have put it in this pattern, he might report it as contaminated.
the inoculation is done in C-shaped pattern.
Exactly. Very good. Very good. So whatever C or whatever you have to tell, C is always better because contamination will not occur in a C pattern. So you're
Yes.
consciously inoculating it in a C pattern,
Yes, sir.
and then you tell the microbiologist and he will look for a growth in the C pattern. So that is what you have inoculated. Any other growth would be a contaminant.
And it's always better to inoculate directly rather than use the transport media because
Yes,
our sample
exactly.
is so tiny.
Exactly.
Yes. And then how will you proceed further?
Ma'am, we have to start on 5% natamycin eye drop, and along with cycloplegics, and since the ulcer is, when you have to observe, since the ulcer is large ulcer and it is involving to the Dates trauma, we can also start on another antifungal medication like 1% voriconazole can be added, And also oral antifungal medications also can be given. And the
What is the
response
role
has-
of oral voriconazole in the treatment of fungal keratitis?
Ma'am, according to the mycotic ulcer treatment trial 2, oral voriconazole alone doesn't have much role in, but if it is given along with the topical medication, it
So what my question is, in what kind of ulcer? I agree with you. In this ulcer,
Ma'am,
I also may have added systemic antifungal. What is the kind of fungal ulcer for which you will add oral medication? What is the role of oral medication in the treatment of infectious keratitis?
ma'am, if it is involving the limbitis or sclerite part is there, oral vascularization is there, and if it is large ulcer with more than 2/3 of the cornea is involving, all these condition we can start on oral antifungal medications.
Do you think the medication reaches the cornea?
No, ocular penetration is not that.
Correct. But in this case, the fungus is deep, right? The infection is reaching up to the endothelium. So there is direct contact with the anterior chamber of the aqueous humor. So
Yes, ma'am.
whenever there is an access of the medication to the body fluids like blood or aqueous humor, then it makes sense to start. So in this case, you can start. But a more superficial ulcer, there is very limited role because the medication will not reach the cornea. Also, when there is a breakdown of blood aqueous barrier, when does blood aqueous barrier break down? What are the situations?
Ma'am, when there is alteration in the tear film stability, in ocular surface stability, a
When you
breach in
have
the
a dry eye, you have a breakdown of the blood aqueous barrier. Listen to the question. You're answering very well. So listen to the question and answer. When does blood
if
aqueous
there is-
barrier?
when there is involvement of the iritis and inflammation is present, and there is breach
When
in
you,
the
breach in the,
Descemet's membrane, corneal.
basically when you have injury or surgery, right? When there is
Descemet's
trauma or
membrane.
surgery, then you have a breakdown of the blood aqueous barrier. So if you have an infection associated with a surgery or with trauma, then you can start oral agents. Otherwise, you start oral agents when you have a deep ulcer. Large ulcer is not only criteria, deep ulcer, so that the aqueous humor forms a portal for the antibiotic to reach the ulcer. What is another very concerning factor over here? Besides the size of the ulcer, the hypopoion, for me, these are number 2 and number 3 concerns. What is a top concern for you in a corneal ulcer? You mentioned that finding over there. I think it's there in your diagram. So, or you mentioned it during the presentation.
Ma'am, it is central. It is affecting the vision.
Those for later. Those for later. Vision is a second criteria, second concern when you're treating a corneal ulcer. Tectonic integrity is the first concern. So, what is the
Thinning,
1
madam.
Yes. Okay.
Corneal
So
thinning.
always make a note of the thinning. Always keep a follow up on the thinning. So even if it is scarring a little slowly, I don't mind as long as not extending. But if the thinning progresses, then it needs more urgent attention. So the top concern for me would be the thinning, which needs to be documented and followed. Great, Arsha.
So how will you know, Asha, that this ulcer is now healing, responding to your treatment?
Ma'am, signs of healing, the epithelial defect should be decrease in the size of the epithelial defect, and the
you can
margins
start
will
with
be,
the symptoms, actually.
symptoms. Patient will be symptomatically better, and also the pain, etc., will be decreased, and the coming to the ulcer, the patient will be the epithelial defect will be healing.
The
And
So
signs
you
of
said
inflammation.
you said epithelial you said epithelial defect will be healing, but what is the corollary over there? I'm saying that that is not a pointer. Why? Because you have, what have you done to the epithelial defect?
scraping
You
has
have
been
scraped
done.
the patient. So what should you have documented at that point? The moment
The
you
size
talk
of
about
the-
corneal scraping, the pre and the post scraping epithelial defect should be marked. Otherwise, you cannot talk about epithelial healing as a follow-up criteria. Okay, sorry. Yeah, I think the other examiner was asking something.
Yes, the redness part would also decrease, no? If
Yes,
it is now healing.
decreased, and the margin will be more defined, and the hypopion size will be decreasing. It will be decreasing. The thinning will be decreased.
Okay. Thank you, Dr. Asa, for the wonderful presentation. And I think you have
One
answered
last
all the
question.
questions.
One last. So what are you going
Yes,
to
sir.
admit this patient? Or what are you going to do? When are you going to follow up? Is it OP admission or how frequently you want to follow up? That's the most important.
We have to admit the patient, sir, and we have to follow up, see the patient every daily to assess the prognosis since there is thinning of the ulcer. And the treatment management has to be planned accordingly. If it is not responding, we have to sort for other measures like intrastromal antifungal, etc. has to be planned. So it has to be under the admission.
Okay, right.
Thank you, Dr. Asa, for the wonderful presentation, and you have answered almost all the questions of such a big judges. And again, congratulations to your mentor, Arjun sir, who has prepared you in such a way that on the live forum and with such a great teachers, you replied wonderfully.
Yeah,
Now I
actually,
would
she did a
like to-
great job. Just before you go to the next person, one
Yes.
second to tell that she did a great
Yes.
job, because it was not just a textual kind of answering. She had a very good grasp of the clinical situation at this early stage in her professional life. So congrats, and do much better than this also in the exam.
Well done,
Thank you,
Asha.
ma'am.
Well done.
Thank you. Well done. Now I invite Dr. Kasturi Bhattacharjee ma'am to invite the next team for the presentation.
Thank you very
Kasturi
much.
ma'am is this member ARC East Zone. Ma'am, please.
Thank you so much. And Dr. Asha, you really presented very well. Like, I joined a bit late, but it was really nice to see how well you presented and how well you have been mentored. So now we have the next case. It is on peripheral ulcerative colitis and keratitis, and that is by Meghna. Meghna is a second-year student from AIIMS Nagpur, and her mentor will be Dr. Pooja Hingorani Bang, and she is an additional professor and HOD AIIMS Nagpur, and Dr. Purvasha Narang, Associate Professor, AIIMS Nagpur. And we have three brilliant examiners. Like, I was listening to my very dear friend, Dr. Radhika, who was, putting up the case so well, along with Professor Giridhar and also Madam Nidhi Pandey. So over to you, and let's go ahead to the second case. Yeah, Meghna, please, you can start.
Good evening, one and all. I am Dr. Meghna. I am JR2 from AIIMS Nagpur, and today I am going to present a case of peripheral ulcerative keratitis. And my mentors are Dr. Pooja ma'am and Dr. Purvasha ma'am. Coming to the case, a 50 years old male, Tyler by occupation, presented to AIIMS outpatient department in January 2022 with chief complaint of left eye pain, dull aching type of pain in left eye, along with redness, watering, along with a nodule seen on the temporal aspect of left eye, along with diminution of vision since 1.5 months. And there is no history of trauma. There is no history of any surgery, no history of a contact lens wear, no history of recurrent redness, pain or watering. There is no history of joint pains, no history of fever, no history of weight loss, no history of cough. He has diabetes mellitus since 3 years, and he is on medication. Before presenting to AIIMS, he was on antibiotic eye drop, for which records are not available. He is on mixed diet and he has no addictions. Family history is unremarkable. On general examination, along with vitals are normal. On systemic evaluation, there is no abnormality detected. But on ophthalmological evaluation, right eye vision in right eye is 6/12, which is improving to 6/6 with minus 0.5 cylinder along 80 degrees, and left eye vision is 6/18, which is improving to 6/6 with minus 1.50 diopter sphere. and IOP with non-contact method is 13 and 14 mm of mercury. Extraocular movements are free and full. Regurgitation on pressure over lacrimal sac is negative bilaterally with normal Schirmer stress. And on slit lamp evaluation, left eye, as the affected eye is left eye, there is left eye conjunctival congestion, and sclera showed firm immobile tender nodule of 6 mm into 5 mm diameter in inferotemporal sclera close to limbus with dilatation of superficial and deep episcleral vessels seen. Cornea in both eyes is centrally clear with arcus senilis in periphery. Anterior chamber depth is of normal depth and clear contents in both eyes. Iris shows normal pattern and color. Pupil is normal size reacting to light in both eyes, and lens is there are no lens changes. And on posterior pole evaluation, cup disc ratio is 0.3:1 with normal size of the disc, and macula appears normal. AV ratio of 2:3, and periphery is within normal limit to the extent visible. We came to the provisional diagnosis in right eye of simple myopic astigmatism and left eye non-necrotizing nodular scleritis, and differential diagnosis of marginal infective keratitis, connective tissue disorder associated scleritis, along with Terrien marginal degeneration, pellucid marginal degeneration were kept in mind. And she was investigated for routine investigations like WBC, which counts are elevated, along with elevated ESR, but glucose, there is deranged glucose levels, there are deranged sugar levels along with HbA1c. Viral markers are non-reactive. KFT and LFT are within normal limit. We have done corneal scraping in the patient, which showed no growth and no organisms seen. Chest X-ray and Mantoux were done to rule out tuberculosis along with any connective tissue disorders, which are negative. Serum ACE levels are within normal limit. RA factor is negative along with ANA. C ANCA and P ANCA are negative along with HLA B27. And this patient was started on topical antibiotics along with cycloplegic agents and lubricating drops with oral NSAIDs, and topical steroid like prednisolone 1% was started 6 times per day. After medicine clearance, he was started on prednisolone 60 mg. 3 weeks later, there is improvement in the scleral nodule seen. But there is a presence of crescent-shaped perilimbal epithelial defect with infiltration from 1 o'clock to 6 o'clock position with thinning and overhanging edge seen 3 weeks later. Later, the patient was kept diagnosis of peripheral ulcerative keratitis. Medicine and rheumatological workup was done to rule out any systemic association, and he was called for regular follow-up. But the patient was lost to follow-up, and 6 months later, he has presented with this kind of picture showing he has stopped all the medication. He presented to emergency with history of vigorous sneezing, and he presented with this picture. This is diffuse slit lamp picture showing left-sided epithelial defect, temporal epithelial defect from 1 o'clock to 6 o'clock position with stromal infiltration, along with corneal perforation seen in periphery along 4 o'clock position, which is of 2 mm into 1 mm with iris tissue plugging, and there is anterior chamber irregular. And he was posted for cyanoacrylate tissue adhesive glue application along with BCL and conjunctival resection. He was restarted on tablet prednisolone 60 mg along with tablet methotrexate, which were started after medicine referral and clearance. 2 months later, again he presented with fresh stromal sterile melt in the paracentral cornea. So we have stepped up his immunosuppression to oral azathioprine 50 mg BD. After 5 months, we have achieved a stable ocular surface. Inflammation was in the inflammation which was in the form of nodular scleritis has resulted in a bluish gray thinning of the sclera. And his vision in left eye dropped to 6/36 with iris incarceration and thinning in the periphery. And his recent picture, diffuse slit lamp evaluation of left eye, shows there is scarring in the periphery, perilimbal area from 1 o'clock to 6 o'clock position. Fluorescein stain is negative with incarcerated iris and irregular anterior chamber can be seen, and there is immature senile cataract of nuclear sclerosis grade 3. There is a definite improvement in the patient from initial visit to 2 years later in the scleral nodule, but there is a thinning. In this case highlights the importance of scleritis presenting with PUK, negative systemic investigations for connective tissue disorder. In 25% of patients, PUK may be the initial presenting feature of potentially undiagnosed systemic vasculitis. So regular follow-ups with adequate immunosuppression is crucial. Under adequate immunosuppression, as he was planned for left eye cataract surgery, and we have ruled out infectious causes before starting immunosuppression. These are my references. Thank you.
Yes, nicely presented, Meghna. Just one comment. Usually in your exam, you will get the case, like you won't know so much background about the case. So you have to present the case like you are seeing the case for the first time. So you won't be knowing so much about the case.
Exactly. This is like you're presenting a maybe a little bit unusual case in a conference. This is not a examination case, in a typical examination case. And it started with scleritis, then it what looks like a Moran's ulcer. Then, and you have completed everything, right? So what?
So Meghna, let's ask you, can you take down your slide so that we can see you while answering? Yeah, so when you see a scleral nodule, like that, what would be your differential diagnosis?
DDs of limbal nodule are
This not exactly a limbal nodule. I asked you a nodule on the sclera or the episclera. So I don't want things like dermoid or pyogenic granuloma and all that. So when you see a nodule on the sclera or the episclera, so what all will come to your mind?
Nodular scleritis.
Before that?
Nodular episcleritis or nodular scleritis.
Anything else? What other inflammatory nodules can you get on the sclera or episclera in that area? Fine. So how did you decide whether this was episcleritis or scleritis, and how did you decide whether it was if it's not if it's not immune, it could be infective as well. So the layer and the etiology, how can you decide based on the presentation?
If it is like marginal keratitis due to Staphylococcus infection, it is most common in superior and inferior. And
no, we're not talking about marginal keratitis. You have a nodule in the sclera. Okay, so it could be episclera or sclera. Okay, and the nodule could be infective or immune, as it finally turned out in your case. So how will you distinguish the layer of the nodule and the etiology, whether it is infective or immune, the nodule?
Scleral nodule will be immobile and it will be painful.
Correct. And
blanching, it will not blanch with phenylephrine, whereas episcleral nodule will blanch with phenylephrine.
Even the vascularity or the vessels around the nodule, what will they look like in a superficial nodule and what will they look like in a scleral nodule?
In superficial nodule, there will be red in color, but deep, they are bluish in color, ma'am.
Yeah, so the color sometimes becomes a little difficult to find out, even though that is the textbook answer, yes. But then you will have finer blood vessels which are tortuous in episcleral nodules, whereas you have more
Deep
straight
blue.
and deep cord-like vessels when you have a scleral nodule. Is there any pointer? There's no definitive one, but is there any pointer which will tell you whether this scleritis is infective or immune? Which is more common, infective scleritis or immune scleritis?
Infective.
Sure.
No, in developing.
How many infective scleritis have you seen till now? You've already seen obviously one immune scleritis. Have you seen any infective scleritis? No. In the cornea, the kind of ulcer that was presented earlier, infection is more common. Whereas in scleritis, immune is more common. Common things are always common in medicine, ophthalmology, life, whatever. So we have to always think of those first, right? So immune scleritis are more common than infective scleritis. If at all it is infective, is there any pointer that you look for? What all can an infection, have in its background? It's just common sense. The history, first of all. There could be a history of some thorn
Pulling
injury,
discharge.
something which has gone into the sclera, which has set up. The infection is coming from somewhere, right? It's a diabetic patient. Your patient was diabetic. And in the eye itself, discharge is less common. But what can you see on the nodule if it is an infective scleritis sometimes?
Pus pointing.
Exactly. So a pus pointing, it will tell you the possibility of an infective scleritis, even though you can have both without the other. Okay, without pus pointing, you can have infective, and sometimes when you have a sinus, it turns out to be immune also. But if you have a pus point, then it tells you about an infective scleritis. If there is one, then what will you do before starting the steroid? If you had pus pointing in this patient, would you have gone ahead and started the steroid? What would you have done otherwise?
We will start on antibiotics.
Before that?
Scraping, we have to
You will try to
scrape.
get the pus out to look at it for evaluation. Now that it turned out to be immune, like you rightly said, the systemic treatment or the systemic angle is far more important than the ophthalmic angle. I have one question for you before the next examiner takes over. Why do you think it recurred after such a nice patch graft was done?
Immunosuppression was not adequate.
Exactly. So when you have an immunosuppression, like in the form of an oral medication, how long do you think it takes to act? Today I take methotrexate, tomorrow my immunity comes down?
No, ma'am.
Yeah.
It will take 2 weeks for it.
More than that. So immunosuppression orally is only a subacute treatment followed by a maintenance treatment. Okay. So when you have something as bad as a descemetociliar perforation, with the help of the internist, you need to pulse the patient with either IV methylprednisolone or with IV immunosuppression to take care of the immediate problem. Otherwise, such a nice diagnosis, such a lovely patch graft, the disease is only waiting to act on it again. So I think you answered that.
So Meghna, you said you applied the glue BCL. So can you elaborate which glue is applied in such cases?
Cyanoacrylate glue was
And can you
applied.
tell me the steps? How do you apply the glue?
Initially, the patient was made comfortable. We will explain the procedure to the patient, and local anesthetic drop was put, proparacaine, and after that,
local or topical?
Topical. Topical anesthetic drop was instilled in the eye, and later initially the scraping was done, and it was sent for gram stain, KOH, and culture. And after drying of the surface, cyanoacrylate glue was applied.
Yes, very important. Why it is very important to dry the surface?
Because it requires for crystallization of cyanoacrylate glue, it requires to be dry.
Okay.
Dehydrated.
And then after that?
After application of cyanoacrylate glue, BCL was placed.
So how much of the glue should be applied? What quantity? I mean, you cannot just measure it, but how do you load it? in what, how do you put it? It is present in what form? It is present as a powder or a solution. You must have done it, no? So in what form it is present? The glue, the cyanoacrylate glue?
Solution.
Okay. So you will load it in a tuberculin syringe and then you will put just one drop. Just one drop. What if you put more of the glue?
If we put more of the glue, then placing BCL upon it also will be difficult.
Yes, that is
And
one point.
it crystallizes and it is an irritant to the eye. So patient will have foreign body sensation.
And it might fall off also. It might heap up and then fall off also. Yes.
Basically, you also need to mention that the other reason for placing such a small amount is that you place it only on the ulcer. You should not place it on the surrounding epithelialized area of the cornea. The moment it goes on to the normal epithelium, it doesn't stick. So that is the reason why it falls off easily. So dry and avoid the surrounding epithelialized area. So these are 2 pointers to remember while placing this.
So what if the defect is bigger?
No, then we have to plan for graft, ma'am. If it is crescent shape, then crescent shaped lamellar patch graft. Yeah.
Okay. And if you don't have any tissue with you, you can try amniotic membrane. You can also try something else available in the eye.
Tillmans patch graft.
Tillmans patch graft. Yes.
Officer Giridhar, would you like to add something?
Actually, that's what it started off as a scleritis. I was expecting as a case presentation, but it was a case report rather. She's reporting the case to us rather than presenting. The entire thing, I'm sure the All India Institute Nagpur people have done a very good job. And from starting to end, I think over 2 years, were you there throughout the case? Because in second year, right? This was, I think, lost to follow up and again came. Probably you should have presented only the Moran's ulcer, what appeared with perforation, that part. Now, really, I have no questions to ask actually.
I have a question to the panelists. So this patient also has developed cataract. So how would you have managed the cataract in this patient? Because the cornea has been melting also, and we all know that the systematically the patient is prone for more of this corneal melt. So what precautions need to be done while doing the cataract surgery?
So first of all, this one thing, the first refraction you said was 1.5 diopters, spherical myopic, simple myopia at the beginning. And then after that, there is no mention of the corneal astigmatism. So that itself, irregular astigmatism itself could decrease the vision. So what is the status of the central cornea? We don't know. And was there any, what is the status of the, of course, now if we have to operate the cataract, we'll have to continue the, under the cover of either steroids or antimetabolites. And since it is in the lower part, we can probably go to the other, the opposite end, upper nasal, left eye, right? So maybe upper nasal incision or even superior incision. And I would definitely take a medical physician's opinion. I'm not sure of the diagnosis as such. What is the real, because everything is negative, including, HLA-B27. So what is going on? What is the physician's opinion about what is the process going on in his body, this Taylor's body? What was their diagnosis? Physician's diagnosis. I would like to know that first before venturing.
I think most of the points were covered. First would be a quiescence of at least 3 or 4 months or even 6 months before the surgery. Quite often we are left with this situation. Only about 30% of the cases we are able to find an ophthalmic or a systemic cause, but otherwise it is based on the appearance of the eye and the response to steroid that we decide it is immune in origin. So after the quiescence period, like it was rightly mentioned, the immunosuppression has to be in place because surgery is a trigger for another episode of immunological melt. So it has to be covered adequately. And third is the corneal condition or the corneal contour has to be taken in mind at the time of DBR calculation. And last but not the least, luckily the area of involvement was inferior. If it was superior, then incision placement has to be tailored accordingly. So I think these are the precautions that need to be taken. Dr. Kasturi has converted us from examiner to examinee at this point in time. I have a question for Meghna. So now that it has kind of healed completely with a little bit of bluish thinning of the sclera, what would you do about that thinning? Would you just watch or just proceed with the cataract surgery, or would you actively treat that area of thinning? What would you do about that? And why?
Now his disease is inactive, ma'am.
So there is no risk because of that thinning? The thinning doesn't bother you? Or would you watch it? Would you do something for it, or would you feel that disease is inactive and just let it be?
We want to keep him under observation with
Why?
immunosuppression.
Why you say the disease has healed? Then what is the problem with that thinning of the sclera? What are the problems?
He had previously also recurrence. So if the immunosuppression is still adequate or not, we will observe.
So there could be a recurrence. So what are the problems because of that thinning? One is recurrence. Okay, if there is a recurrence in that area, then you have very little scleral tissue left, right? So then what second problem? What is another thing that you need to follow up?
Astigmatism, which...
The thinning in the sclera is not a contributing factor for the astigmatism. It's more that thinning. How about glaucoma? What is the relationship between glaucoma and scleral thinning? You need to keep the pressure under control, otherwise... It's simple logic. When pressure is high, what happens to the area of thinning?
Any trauma can lead to...
When I'm asking about glaucoma, you should not talk about trauma. I'm very happy that you mentioned trauma. Okay. So recurrence, injury, and eye pressure. These are three things that can make that area of thinning worse than it actually is. So these are three things that need to be controlled. Okay. To prevent that area of thinning, which has healed nicely, from getting into more trouble. Okay, so the answer of trauma was correct, but you should not answer the wrong aspect when another aspect is being questioned. But otherwise, these are the three things that you need to keep in mind. You have to look for immune recurrence, you need to look for IOP control, and you also need to make sure that the patient doesn't get injured in the eye because that area is more vulnerable. So your answers are right, but put them in that order.
So you have to examine the posterior segment, because scleral thinning is part of the disease process. So is there any staphyloma or any other posterior scleritis? So how would you do that? Because your cataract, you can't probably can't see the fundus clearly enough.
B scan.
Okay, so in this one related question may not be for this case. What is the T sign? You heard of
posterior scleritis.
That's mostly for an infected case.
What causes the sign, Meghna? What he asked now. Why do you get a T sign? Since you said scleritis, posterior scleritis. Is it the sclera you're seeing, or what is it that you're actually seeing there? Think about it.
Between supralamellar space, due to fluid accumulation.
Excellent. So the edema is what gives rise to the T sign. So that makes it slightly non-specific, except that we can diagnose posterior scleritis or suspect posterior scleritis if there is a T sign.
Any simple symptom, what will be the patient's complaint if there is a scleritis, posterior scleritis? I can give a clue. Especially, underneath where the muscles are attached, if that sclera is inflamed there.
Pain on eye movements.
Exactly.
So in your particular case, even though all the investigations were negative, still I would think that there must be a systemic component. And I don't think you can make a diagnosis of Moran's because scleritis, you said scleritis is present. So in Moran's, there is no scleritis, no? And it is idiopathic after you have excluded everything else. So there are so many, a battery of investigations. I don't think it could have been possible in your center, maybe. So still systemic workup maybe can be done.
If you glue the patient, how do you know the ulcer is healing, the PUK is healing? What tells you that the glue has done its job?
When there is epithelialization, the glue will fall off.
Very nice. Okay, so if the glue falls off immediately, today I put the glue, tomorrow it falls off, then you've not put it properly, right? You've not dried or you put it on the epithelium, okay? But if it stayed there for some time and then it slowly starts loosening, then you know that it is getting epithelialized. Good answer.
Very nice presentation.
9 o'clock.
Yeah. So I think, thank you very much. Thank you both, Dr. Arsha and Dr. Meghna, and many thanks to all the three mentors, Dr. Arjun, Dr. Purvasha, Dr. Pooja. And I'm extremely thankful to the three great examiners, Dr. Nidhi Madam, Dr. Radhika, and Dr. Giridhar Sir. Thank you very much for being with us. And we also learned a lot. It's very interesting. That's why I had a query. I got an opportunity to place my query. So thank you all very much. And again, we will meet very soon. And good night. And thank you, each one of you.
Congrats to Meghna and Purvasha, and thanks Dr. Kasturi and Dr. Prashant, and to all the people on the forum for staying through.
Thank you all.
Thank
Well
you
done.
for the
Well done,
guidance.
Well
both of
done.
you.
Well done, the students. Well done.